back to the adjuvant setting and the potential role for adjuvant bisphosphonates. So just to get you all oriented, this is a slide of bone remodeling and the bone cells, the osteoclast and the osteoblast, osteoclast resorbing bone, osteoblast making bone. And I don't want you to worry about the detail of this slide, but it's just to make the point right up front that bone metabolism is completely different in the presence of reproductive hormones compared to after the menopause. So estradiol and probably other reproductive hormones are very important regulators of bone cell function. So they affect this signaling between bone cells. I don't think you need to know the details of these mechanisms, but don't be surprised, as I'll show you in the clinical data, that the outcome for changing the bone microenvironment is very different depending on whether women have or do not have circulating reproductive hormones, because the whole microenvironment is estrogen dependent. So bone metastases develop as a result of cancer cells getting into the bone marrow and being attracted to the bone surface and then stimulating bone cells to break down bone for themselves. So cancer cells cannot destroy bone directly. You have to be able to produce high concentrations of acid to break down bone because it's such a tough substance. So cancer cells, as far as we know, cannot destroy bone directly. They have to use the normal bone cells. And they stimulate bone cell function to break down bone, and that stimulation of bone cell function seems to create what we call a fertile environment or fertile soil for the cancer cells to survive in, because bone itself produces growth factors and cytokines. We call that the vicious cycle, and then on top of that, there's all the effect of the immunology, the stem cell biology, and the endocrine profile within the microenvironment, which is making this a very complex process. So let's simplify it down to a very unidimensional level. We've essentially got this process going on. So this is the bone surface, and this is a clump of tumor cells that are sticking to the bone surface, and they stimulate bone cell function probably by activating receptors more on the osteoblast than directly on the osteoclast. And the osteoblast produces rank ligand. This is the main signaling molecule for bone cell function, rank ligand. And of course, we have a drug to target this now, denosumab. But rank ligand drives the osteoclast, and if you treat the patient with a bisphosphonate, that destroys the osteoclast and breaks this vicious cycle. Here's a picture of an osteoclast just to show you how it works, how it gets poisoned by the bisphosphonate. So this is a cartoon of a bisphosphonate-coated bone. The green is the bisphosphonate. The osteoclast releases hydrogen ions, acid, into the microenvironment. That dissolves the bone, and the bisphosphonate goes into the cell by endocytosis. And any cell that takes on board a bisphosphonate will be poisoned. The reason these drugs are so well tolerated is that they go so rapidly to bone that most normal cells and most cancer cells outside bone don't see very much of the drug. It goes to bone within a few minutes, with the rest coming out in the urine. But once into bone, and you can see there a pretty picture of it being taken up into a real cell, it then inhibits this pathway. And this pathway is very important for cell signaling, for the production of prenylated proteins. So bisphosphonates inhibit this enzyme, FPP synthase. This pathway is also involved for cholesterol production. So it's a very important cellular pathway. And in fact, statins have some effect on bone cell function because they also act on this pathway. But anyway, the bisphosphonates inhibit this, go back. The bisphosphonates inhibit this pathway and block these proteins that are required for cell survival. And so any cell that a bisphosphonate gets into is likely to go into apoptosis. In addition, there is a boosting of certain immune cells known as gamma delta T cells, which may have some clinical relevance. We don't know. It certainly is what causes the fever when you give a bisphosphonate. Whether it's useful anti-tumor activity, we don't know yet. The other way that we could tackle the bone microenvironment is with this molecule. This is denosumab, which is a fully humanized antibody that binds very specifically to rank ligand. And for metastatic disease, we give it subcutaneously every month. For preventing bone loss, it's given every 6 months. So a bit like bisphosphonates, different schedules depending on whether you're trying to prevent bone loss or treat advanced cancer. So rank ligand denosumab blocks rank ligand specifically, and in that way inhibits the osteoclast and inhibits the vicious cycle. Let's turn to what's going on in bone to understand why changing the microenvironment might be important. There are at least 2 phases of bone metastasis. The first has already probably happened by the time we make the diagnosis of breast cancer. The cells that are going to cause metastasis have already left the primary site, and they have gone to the bone marrow microenvironment, and they are attracted to these normal cells, these hematopoietic stem cells, and they go into what's called a niche, like a little cave in the bone marrow, right up against the bone surface, and the normal cells create literally a physical barrier to help preserve the cancer cell and provide nutrients and support for the cancer cell. And that is where we think cancer cells can remain, we call it quiescent, asleep, dormant, call it what you like, for many, many years. And that's the basis of the fact that breast cancer and prostate cancer is able to relapse years after, because the cells that are going to cause the relapse are physically encapsulated within this niche, and they're not proliferating, so they're can be very resistant to standard therapy. So the cells remain in this dormant state for years, and then they will wake up. Now, what evidence is there that that bone cells are are important? Because these stem cells bind to the osteoblast. So what's the evidence that the osteoblast is important? So I just want to share with you some preclinical data, which I think is quite intriguing. We've done some work in mice where we, just for a few days, give them parathyroid hormone or control. And what parathyroid hormone does is it increases the number of osteoblasts. So you give parathyroid hormone just for 5 days, and you get a short-term increase in osteoblasts for about another 5 days. So just 10 days of stimulating osteoblast activity. What does that do to the ability for cancer cells to go to bone? So now if we inject those animals with tumor cells, what we find is that those animals that have had increased osteoblast activity, the cancers form metastases in the bone marrow much more reliably than in the control animals. And that's even though that we only treated for the first 5 days and the osteoblasts were back to normal after 10 days, you get this ongoing increase in tumor. So a short-term effect on the bone microenvironment can have a long-term outcome in terms of metastasis. And mirroring this is what we do is when we sacrifice the animals, we measure the circulating tumor cells in the animals, and you can see that there are far fewer circulating cells in the parathyroid hormone-treated animals, suggesting the cells have literally been sucked out of the circulation into the bone marrow, where they're causing metastases. So obviously we can't test this very well in a patient, but at least in the animal models, this seems to be relevant. So after the homing, we then have, many years later, the cells wake up. We don't know why they wake up. And they start to proliferate, and they can do one of at least two things. They can start to cause a bone metastasis, or they can go elsewhere. They can go to the liver, the lung, they can even go back to the primary site. Now, bisphosphonates inhibit many processes involved in metastasis. They can inhibit angiogenesis, at least in the bone marrow. They may have some synergy with chemotherapy. But obviously their main effect is on bone cell. But we've been interested in synergy with chemotherapy. This is a very complicated slide, but the point that it's making in soft tissue tumors grown in mice is that when you combine doxorubicin with zoledronic acid, you get sequence-dependent synergy, so the tumors don't grow when we give the bisphosphonate after the chemotherapy, because there's less angiogenesis, less proliferation, and more apoptosis. And we think that there may be something in this in patients. There's some data to show neoadjuvant breast responses are a bit higher, at least in some groups of patients, if you combine chemotherapy and bisphosphonates. But in terms of adjuvant benefit, we're not sure whether this is important. We've done a neoadjuvant study to look at this, where we've done a biomarker study, which was recently published, 40 patients, neoadjuvant chemotherapy alone, or neoadjuvant chemotherapy with the bisphosphonate given on day 2, just like we did in those animals, to get synergy between chemotherapy and bisphosphonate. And we take repeat biopsies, which allow us to measure the growth index. And what we see is that there's not much difference at day 5 in the tumors between the two groups. But at day 21, when we're about to give our second cycle of chemotherapy, all the patients who've had combined therapy have high rates of proliferation, and almost all of the patients with chemotherapy alone have low rates of proliferation. Now, if you've got high proliferation, that's going to make your tumor potentially more sensitive to chemotherapy. So it may be that the increased neoadjuvant response that we saw in our study and one or two other groups have suggested is effect on cell signaling and cell cycling, that we're stimulating growth index, making cells more sensitive to chemotherapy. The other effect that these drugs have is that they're able to destroy disseminated tumor cells. So you can look at disseminated tumor cells in the bone marrow, and there are at least 4 studies that have shown if you give patients zoledronic acid and then repeat the bone marrow biopsy, those that have the bisphosphonate are more likely to become DTC negative than those that just have regular adjuvant therapy, suggesting that those tumor cells in the bone marrow are either being killed by the bisphosphonate or they're being encouraged to move somewhere else. So what is the evidence that these drugs are helpful in the adjuvant setting? What are the clinical trial data? The idea of giving bisphosphonates to prevent metastasis is not new. And these 3 trials were started in the 1990s with oral clodronate, Trevor Poles, Inga Deal, and Tina Sato, 3 important studies. And the best of these was from Trevor Poles. It was the largest study. It was placebo-controlled. And he got a positive result. He showed that clodronate given to early breast cancer reduced bone metastases and improved overall survival. But it was not generally accepted. It didn't get approval, particularly the US were not impressed sufficiently with the data. And so clodronate never got a license in the adjuvant setting. What Trevor also showed, although I don't think even he really made much of this, was that all the benefit was in the postmenopausal patients. You see the survival advantage here is all in postmenopausal patients. Nothing's happened in premenopausal. And the bone metastasis, similarly, not much difference in premenopausal, but quite impressive in postmenopausal. And then it all went very quiet for quite a few years, 5 to 10 years, until Michael Ganant presented these data from the well-known APCSG12 study, initially at ASCO in 2008 and then published. And in his study, which I'm sure is familiar to many of you, he showed improved disease-free survival. This is the most recent update from at 7 years median follow-up, showing about a 30% reduction in recurrence. And of course, these data were published in the New England Journal. And in this study, there's now a survival advantage as well. I mean, the patients are doing fantastically well in both arms of the study, but there's about a 30-40% improvement in overall survival. So on the back of this study, everybody thought this is what we should be doing to our patients, and it started to creep into routine practice. Another study that looked quite positive, it's only recently been fully published, but data were emerging over recent years, is the ZOFAST trial. You may have been part of this trial. This was a trial run by Novartis looking at letrozole alone or letrozole with zoledronic acid. So either immediate bone protection or just introducing the bone protection if patients got osteoporosis. So of course most patients in the control arm didn't get letrozole. And what we showed in the recent publication after 5 years follow-up was just like Michael Ganant, in this postmenopausal population, about a 35% improvement in relapse. And this reduction in recurrence was not just in bone, it was also appeared to be at other sites of disease, local regional disease and visceral disease. So you think, well, Michael Ganant's treating premenopausal women, ZOFAST is treating postmenopausal women. This trial, the AZURE trial, in all groups of patients, must be going to confirm this. Of course, Michael Ganant's study was not really in premenopausal women because all of his patients received gasolin, so they were all made postmenopausal. But anyway, this is the AZURE trial, which was designed to be a much larger pragmatic study, 3,000 patients with or without zoledronic acid, and we gave quite high frequency treatment rather than bone protection treatment. So you can see monthly therapy and then less often. We treated for 5 years, and we really, I think everybody thought this was going to be a positive study. We don't need to go through the statistics, but we've just presented the final analysis after 940 events at the recent European meeting in Amsterdam, which I'll share with you. But we published a lack of benefit in analysis in the New England Journal, at least lack of benefit for the overall study. These are the characteristics of the patients. They were all node positive. About 80% were ER positive. And we split patients by menopausal status into premenopausal, what you might call perimenopausal, within 5 years of their last period, definitely postmenopausal, and of course some patients don't know where they are. Unlike the Austrian and the ZOFAST study, almost everybody received chemotherapy in this trial, and consistent with practice in the early 2000s, only about a quarter received a taxane, but they had pretty decent chemotherapy. So the data I'm going to show you are the most recent analysis. So we've got over 1,000 invasive disease-free survival events, we've got a follow-up of 7 years, and we've got good data flow from all our centres. And we really thought this was going to be a positive study, but unfortunately, life is full of surprises, because this is the primary endpoint of the trial. It's terribly disappointing, wasn't it, when you first look at it? 10 years work, over 3,000 patients, no difference in outcome on an intention to treat analysis. And that's not going to change with further follow-up, not with 7 years median follow-up, that's not going to change. So this is telling us something, that the Austrian study and the ZOFAST study, not that they're necessarily wrong, but we need to look more carefully at the patients we've treated. This trial was unselected. So we had some planned subgroup analyses, And what we find in the postmenopausal women is that there is a significant benefit, about a 25% improvement. We have more events than the Austrian study, so I think this is fairly secure. This is a bit busy, but it's basically making the point that the benefit is seen in ER-negative patients at least as much as in ER-positive patients. So you can see the hazard ratio for ER-negative postmenopausal patients is really pretty impressive, 0.68. If you're premenopausal, it almost looks as though the ER-negative patients are doing worse. It's not statistically significant, but it's certainly going the wrong way. For the ER-positive patients, not so much difference. We're now reducing bone metastasis. So just like the POLE study, we can certainly say that this treatment reduces bone metastasis. So if we could pick out patients who are going to get bone metastasis as opposed to liver metastases, this would certainly be a very attractive treatment. So we're reducing bone metastasis. And we're reducing bone metastasis irrespective of menopause. So what we're looking at here is the hazard ratio for bone metastasis by menopausal status. And you can see that they're all about 0.8. Doesn't matter what your menopausal status is for preventing bone metastasis. But this is the most interesting data that's emerged from this study. What happens to a patient in terms of metastasis everywhere else is hugely affected by their menopausal status. So if you're postmenopausal, this treatment seems to also prevent liver metastases and local regional recurrence. So benefit in bone plus benefit outside bone means benefit overall. If you're premenopausal, these patients are getting more liver metastases. So although there's a benefit in bone, that is completely wiped out by or apparent stimulation of disease outside bone. And the test for heterogeneity is extremely strong. That's a very striking heterogeneity test. So we think that this is important. We know that cells don't just go from the breast to the distant organs. They can go elsewhere. They can go to other metastatic sites. They can go back to the local regional sites. So maybe, changing the bone microenvironment doesn't just change bone metastasis, changes everything else. So we're now in a situation where the picture is a bit confused. And it depends whether you like taking the decision on subgroup analyses or not. This is a meta-analysis of all the studies that are reported results based on menopause or some surrogate of menopause, suggesting that there's about a 20% improvement. If that's true, that's worth having. That's as big as the difference between an aromatase inhibitor and tamoxifen, so that would be worth having. But I think, for the definite answer, we're waiting for the Oxford meta-analysis, and we will be presenting a meta-analysis of somewhere between 16 and 18,000 women in randomized bisphosphonate trials at San Antonio. And I'm not allowed to tell you the results of that meta-analysis. You're going to have to wait for San Antonio. But I think once that is out in the public domain, clinicians will be able to make their own decisions about whether this is something that should become part of routine practice. There are other trials with denosumab. The Austrians are doing a study with low-dose denosumab, and there's a global study run by Amgen, which we'll report in a few years' time. I'll pass on that. So I'm going to move on quickly because this is a bit... I'll leave the preclinical work. So, and wrap up. So, what I hope I've managed to convince you is that there is a rationale for adjuvant bisphosphonate. So the bone microenvironment is really important in the metastatic process, not only for bone, but probably for other sites. It's like the conductor of the whole metastatic orchestra. And the clinical trial results are confusing, but I think as we look into them more logically, there's a very clear pattern emerging. This is a good treatment if you are postmenopausal, whether you're postmenopausal just through age or postmenopausal because you have your ovaries suppressed. But for reasons we don't understand, this treatment should not be given to women who are still menstruating, because there is the potential to, it seems, to stimulate metastasis outside bone, and we're doing a lot of work to try and understand that. So there's just some acknowledgements for the work that I presented, and particularly the laboratory team. I skimmed over some of that, and the Azure team, you'll recognize some of those names, and very happy to take some discussion and questions. Thank you.
When we first learned this prophylactic zoledronic acid 4 years ago, we started to recommend, it is not covered by insurance system, but every 6 months for 3 years, yes? And what is disappointing that the number needed to treat. So we need to treat 225 in order to avoid one bone metastasis. Is it true? So the advantage is present, but only in few patients. How we can select that patient?
Well, I would suggest that we use risk factors for recurrence. So the Austrian study took very good prognosis patients. So their survival is 95%. Well, I'm sure survival of your patients isn't 95%, and it's not in my practice either, particularly for node-positive disease. So I think, node-positive patients, because the numbers needed to treat depends on the absolute risk. And, if the meta-analysis confirms